Hi, everybody. Well, welcome back. Just checking everybody can hear me.
We can. Thank you, Juliet. Thank you.
That's good. I'll kick off then. Welcome back to the next part of this session. My name's Juliet Spiller, and I'm a consultant in palliative medicine. I work at the Marie Curie Hospice in Edinburgh, so I'm really delighted to be chairing the next half of this session. It's been a fascinating first half. Thank you so much to the team for all the presentations. That was amazing. So it's great to be presenting this next session. The focus is switching to delirium and its presence within palliative care settings, whether that be inpatient hospice or community settings or hospital settings, focusing on the assessment and some of the work that we've been doing, particularly based around the Edinburgh and Glasgow hospices, looking at how we manage this really tricky symptom and condition within palliative care settings. So I have the privilege of presenting the initial context to the work that you're going to hear from Anne Finucane and Hilary Nailon later on. I'm just very aware that I'm presenting work which has been led by Dr. Elizabeth Arnold, who unfortunately can't be with us today, but I'm going to give you a wee bit of context for some of the current projects that we're working on, the recently published work that has come from the team, and then introduce Anne and Hilary, who are going to set the scene for some, hopefully some very helpful resources and some information which may influence your practice. So please do put any questions within the chat for either myself or for Anne and Hilary as they present, and there will be time at the end of the session for questions. So I'm going to kick off now by sharing my screen, and hopefully you can see the first slide. Great. So delirium within the palliative care setting, as I say, I'm just going to set the context for the presentations that you're going to hear from Anne and Hilary later on. It's a significant problem for anybody working within the palliative care setting. It is absolutely the most prevalent neuropsychiatric disorder in advanced cancer, and also in any patient with any advanced irreversible illness. We've known that for a very long time. So it's roughly a third of all admissions to inpatient palliative care units have delirium. And this figure gets much greater as people progress into their final days. So anything up to 88% of patients in their final days have been shown in studies, as I say, as early as 2000, but even in the latter studies, that those prevalence figures don't change. So it's a significant problem for palliative care at any stage of the palliative care trajectory. And it's also an issue for patients within the community settings as well. So a study by Rekia in 2022 showed that roughly 57% of patients in their final days in the community, 23% of community hospice patients and 57% in their final days had delirium. And most notably, it is the most common reason for acute admission for end-of-life care to the inpatient palliative care setting. So, and I think that's a fact that's going to resonate with any clinician in palliative care. The other thing that we know about delirium is that it's a very poor prognostic sign. So any patient who has delirium, immediately you're thinking that within the palliative care context, this is not a good sign. And patients who have one episode of delirium are very likely to have a recurrent episode of delirium, and recurrent delirium is an even worse predictor of mortality and poor prognostic sign. So the diagnostic criteria really focus on these 4 areas that are laid out here in the DSM-5 psychiatric diagnostic manual. So this is the kind of gold standard diagnostic criteria for delirium. So you're looking for disturbance in both attention and awareness. So that ability to focus, to be oriented to your environment is lost. Disturbance in cognition. So that can be a number of different areas of cognition. Often it's a very global cognitive deficit, but sometimes it is just specific to memory, or just a disorientation, or hallucinations, or perceptual disorder. The other classic diagnostic criteria of delirium is that it develops over a short period of time. So this is one of the ways in which we can distinguish between delirium and dementia, for example, where there's often confusion between the two, but it's classically a short period of time. So you can identify with a family the time period where the patient wasn't like this, and that things have changed over days or weeks. There also has to be a very clear physiological cause for the delirium, and in palliative care there's often not just one cause, there's often multiple causes or potential causes. So when you're looking for the underlying cause, you often end up with a list of maybe 5 or 6 potential things. So in palliative care, what things might make you wonder if delirium is present for a patient? And these are all the sorts of things that have been identified from the research. So often it's just the patients become slightly more withdrawn or slowed down. Often, you can have, as you're having a conversation with somebody, they may initially be engaging, but then just start talking off the track or start rambling. So they start off answering a question and then start talking about something maybe slightly related, but just not quite focused on what you were asking. Often there's a sense that patients who have particularly early delirium are maybe come across as impatient or slightly angry or suspicious or frustrated, and these are maybe the patients where all of a sudden they become a little bit difficult. So I always think that's quite a warning sign when the nursing staff report that oh gosh, they're really irritable today. It's been really hard to manage things this morning, and they're described as a difficult patient. That makes me immediately think that somebody might have underlying delirium. Another quite frustrating feature of delirium is often they can be very settled through the day, but become increasingly unsettled at night and very demanding, distressed, maybe agitated as the night comes on. And so sometimes you find that the night staff are reporting somebody's had a terrible night, and then they come back the next night and nothing's been done through the day because the patient was really, really settled. So the day staff have not recognized that somebody's had delirium, and because they've been so settled, nothing has been changed. So again, this can be a huge disruption for inpatient teams, particularly through the night, and a sense of frustration for the staff and the patient, and often the other patients, impactful on the other patients too. One of the publications that came out from our team was it was actually a medical student who was with us, but this study was refreshed and published by Dr. Arnold and the team, looking at the management and identification of delirium within our inpatient setting. And one of the things that came out of it was how reluctant staff were to actually call it delirium. So they used all sorts of other words, and it was often evident, from the way that nurses particularly were describing the patient, but also the medical teams, that in fact this patient did have delirium. But they would use other terms like restless, like disoriented, muddled, drowsy, distress, anxiety, hallucination, all of these. So Liz created a word cloud for the most commonly used terms. And again, I think you'll resonate with many of the terms coming through. And why do we need to think about screening? Well, hyperactive delirium is one of the 3 subtypes. There's hyperactive, hypoactive, and mixed type. And the hyperactive delirium subtype we all recognize. So these are the patients where everybody on the unit knows that somebody's got delirium because they're up, they're agitated, they're distressed, they're causing havoc, they're often wandering. These are the patients that are on the go and really very noticeable. So I don't think we miss too many of these patients. However, the far more common subtype, as we know from the research over many years, is the hypoactive delirium subtype. And these are the patients that we don't notice. These are the patients who are withdrawn and slowed down and just come across as very fatigued. So we have actually known that we miss these patients for a very long time. This was one of the first research projects that I was involved in. Certainly as a trainee, that was where my interest in delirium came from. But it was Peter Lola and his team back in 2000 that really identified that of all of the patients in palliative care with delirium, between 78 and 85% of these patients have the hypoactive subtype. And what we know about this subtype is that it's very easily misdiagnosed as depression, fatigue, or even that the patient has, that it's impending death. So it's very, very concerning to think that up to 50% of palliative care patients who are actually diagnosed with depression may in fact have had hypoactive delirium. So that was a study published by Maeve Leonard back in 2009. Despite that, despite knowing that we have to be screening for this in palliative care, a survey that was published in the BMJ in 2020 showed that only 37% of palliative care specialists actually use a screening tool for delirium, and only 5% of palliative care specialists use a screening tool routinely on admission of patients to the IPU. So why is it important to pick this up by screening? Well, if you pick it up early, you can intervene early, and there's increasing evidence, particularly over the last few years, that taking a multidisciplinary approach to delirium identification and management allows you to start to unpick why it's happening and to reverse the underlying cause, and also to manage the symptoms better. So if you pick it up early, you can identify any easily reversible causes such as infection, constipation, dehydration. There's all sorts of things which can be quite easily reversed if appropriate within the inpatient setting or even in the community. We try and think now about having delirium-aware multidisciplinary team and not just thinking about the clinical staff. So including volunteers, maybe housekeeping staff, in that awareness of what delirium is and how to take a multidisciplinary approach to management can make a significant difference to symptom management and helping patients with the distress and helping families with the distress. And part of that MDT approach is family and carer support and education. And you'll be hearing later on from Hilary around some of the resources that we've developed to support that essential aspect of delirium intervention. So it's really a whole team approach to the environment that the patient is being cared for in, to their sleep hygiene, to their nutrition, to their hydration, to there's all sorts of aspects that are nothing to do with the medicines that really support the whole person approach to managing delirium symptoms. So supporting the clinical team to also support the families and the carers, and that requires significant and ongoing support and education for the clinical teams. And as a team, it's really essential that everybody agrees with the family and hopefully the patient the target symptoms that are to be treated, agree comfort care goals, and agree what the triggers for medications might be. And the literature is still out on that aspect, although there is increasing evidence that for significant agitation and distress, it's still worthwhile considering medications for managing this symptom. So the assessment tools that are currently that have been put forward over the years are here: the confusion assessment method, Memorial Delirium Assessment Scale, which is more for research, really. The nursing delirium screening scale has been used in some significant research studies recently. However, it's the 4AT, the 4A's test that we have been looking at in the Edinburgh and Scotland team, really because it's one of the best embedded tools used across acute services really up and down the UK and actually internationally now. So the 4A's test, which was developed and validated in 2014. The link here, I think we're going to put a link to this in the chat for the 4AT website. If you are not aware of the 4AT, please have a look at the website and the teaching tools for that. But again, we'll tell you a little bit more about how that works in palliative care in the video resources later on in the talk. And one of the most significant publications, I think, that's come out of certainly the Scottish delirium research team recently is this, which is a validation study. So I think anybody in palliative care research will understand how almost impossible it is to do a validation study in palliative care research, full stop. So really all credit to Liz Arnold and the team for taking this on and completing an extremely successful validation study across the Edinburgh and Glasgow hospices. And what Liz and the team showed and demonstrated really beautifully is that it is possible to use the 4AT delirium tool to screen for delirium within the inpatient palliative care setting. So Liz showed that the 4AT has a sensitivity of 89% and a specificity of 94%, so pretty robust for use as a screening tool within the inpatient palliative care setting. So that's the point at which I'm going to pass over to Anne Finucane, who's going to tell you a little bit more about what we did with the fact that the 4AT can be used and how we looked at implementing it within the palliative care setting. So I'm going to stop sharing my screen now, and I'm going to pass over to Anne Finucane, who's going to tell you about the next stage of the work.
Great, thanks, Juliet. Okay, just you can see that okay.
Yeah,
right. Okay, so thank you very much, Juliet. So in my part of the presentation, I will focus on our current study, which involves developing a multi-component intervention to improve delirium assessment and management in hospice inpatient settings. We'd like to acknowledge our wider team, which includes Dr. Liz Arnold, who, as Juliet mentioned, has been heavily involved in all aspects of this work, Professor Alistair McNulloch at the University of Edinburgh, who developed the 4AT delirium assessment tool, Professor Mark Pearson at the University of Hull, who provided guidance on implementation, and importantly, our public representative, Angela McCullough. And we are very grateful to Marie Curie, who funded this work via a small research grant and an impact grant. So as background, at our Marie Curie Hospice in Edinburgh, we've had a particular interest in delirium since Juliet published her first paper on delirium in 2006, followed by her work with international collaborators describing the phenomenology of delirium in palliative care settings. In recent years, we have conducted review studies, quality improvement projects, audits, and case note reviews to further understand delirium and its management in terminally ill adults. Right. As Juliet mentioned, we know from the wider literature that delirium is prevalent amongst people with a terminal or advanced progressive illness. Our own small-scale studies reflect this, and at our hospice in Edinburgh, about 1/4 to 1/3 of patients screen positive for delirium on admission to the inpatient unit, with the number rising in the last days and hours of life. Most recently, we have focused our research on delirium assessment and have shown that the 4AT is a useful tool to screen for delirium in patients admitted to hospices. We are now keen to extend our work on assessment to include good delirium management and to encourage best practice regarding delirium care, starting in our own hospices. So the aim of our study was to co-develop a systematic approach to improve delirium care in hospice inpatient settings. We undertook this work in the inpatient units at our Marie Curie Edinburgh and Glasgow hospices, which you can see here. So our study involved the following steps. First, we examined the published evidence and practice guidelines to identify latest perspectives on good delirium care. Next, we conducted a baseline audit of 100 case notes. 50 from each hospice, to examine our current practice. We also circulated an anonymous survey amongst IPU staff to assess their knowledge and perceived confidence in relation to delirium care. Our next step involved linking in with stakeholders, specifically staff members, to identify a range of interventions or steps that could be taken to improve delirium management. We identified a set of intervention components, which Hilary will share with you shortly. We then spent a few months implementing these changes and are now in the final stage, which involves a post-intervention audit, a follow-up survey, and focus groups. For this presentation, I will briefly share some of our baseline data. So we audited 100 patient notes from consecutive admissions, 50 at each hospice site. We used DSM-5 criteria to retrospectively judge whether each patient admitted had delirium. We judged that 28% of patients had symptoms of delirium on admission, a finding which is aligned with our previous research studies and the wider literature. However, we found that delirium screening was not common, and only 25% of patients had been formally screened for delirium. While this is a minority, it is a higher proportion than is typically found. As Juliet mentioned, in a study of 220 specialist palliative care staff published in 2020, Rebecca Woodhouse and colleagues reported that only 5% routinely screened for delirium on admission. Clinical judgment is most commonly used, and screening often occurs when symptoms are already evident. Of those retrospectively judged as having delirium, only half had been screened, and overall, only 10% had delirium documented. There was a significant variability in rates of screening across each hospice, due in large part to the fact that both doctors and nurses played a role in delirium screening in one hospice, whereas doctors only were responsible in the other. We also found that it was difficult to distinguish specific delirium care from routine practice in the notes, so we could not readily identify approaches to delirium management. In line with previous research, we found that the word delirium was infrequently used. Instead, confused, muddled, disoriented, agitated, and drowsy often appeared, or phrases like struggle to stay on topic, seeing shadows, and cognitive impairment. You'll see that these words are very reflective of what was found in the earlier work Juliet mentioned. Findings from our audit helped inform the development of our intervention. We realised that there was a need for our intervention to improve knowledge on the prevalence of delirium at end of life, to share benefits of routine delirium screening, to introduce a brief delirium screening tool, to upskill nurses and healthcare assistants to screen for and recognise delirium, and to encourage staff to use delirium or possible delirium in patient notes. We circulated an anonymous online questionnaire to all inpatient unit staff at both hospices. This was completed by 45 staff, including 20 nurses and 10 doctors. Overall, staff had a good knowledge of risk factors. However, most underestimated the prevalence of delirium towards end of life. Nearly all agreed that they had a role in identifying if a person had delirium, though only 1/3 routinely screened for delirium. Only 4 in 10 agreed they had had adequate training. Taken together, the findings from the audit and survey suggest further upskilling and education would be welcome and might further improve delirium assessment and management. So now I'll hand over to Hilary to talk about elements of our intervention. But while Hilary's getting her slides ready, I invite you to share in the chat whether you use an informal or a formal delirium assessment tool, what tool you might use, and just to reflect on what it might take to convince people you work with to use the 4AT. So over to Hilary.
Thanks, Anne. I'll just share my screen. Right, hopefully you can see that. So following on from what Juliet and Anne have talked about, I'm going to talk to you about the audiovisual resources that we produced for families and professionals to support delirium assessment and management. Before I go into that, I want to just briefly touch on some of the interventions and activities that we have developed with the aim of improving delirium care. These range, as you can see on the screen, there's a selection of them. They range from online, print and video resources to education and training activities. We have produced 2 animated videos, which I will talk about in more detail shortly. In terms of our online resources, we've worked closely with our colleagues from Marie Curie Information and Support Services to update the delirium information on the Marie Curie website. So there are 2 different web pages on delirium on our website. One is for members of the public, so that would include obviously patients and their loved ones, and another one aimed at our healthcare professionals. We have also now embedded our new delirium videos within those pages, so these should be a really useful resource. Next, our MDT, which Juliet has already mentioned. It was really important for us to ensure that all members of our MDT are delirium aware. And we did this through widespread sharing of us and various education sessions with the different teams. It was also really important that we ensured our nursing and medical staff were confident in using the 4AT assessment tool, and then when necessary, taking these 4AT scores to our MDT discussions. And as Juliet said, we have also shared our videos with our non-clinical colleagues within the team. So for example, our housekeeping teams and our volunteers, so that they too can be delirium aware and can help to support us in creating an appropriate environment for someone who is experiencing delirium. In terms of training and education, we've run a wide variety of education sessions with lots of different teams within our inpatient units, including small group face-to-face sessions with all of our nursing and healthcare assistant staff across both our sites. Delirium has also been included in the mandatory updates for our nursing staff, and it's now also part of our induction programme for our rotating medical staff. We've recently secured further funding from Marie Curie to progress a number of other pieces of work that will impact on delirium care. So firstly, we plan to create a new Marie Curie branded booklet on delirium, which we believe will be a really useful resource for patients and their loved ones. And we also plan to do some final work on a PowerPoint video resource that our colleague Liz Arnold has produced that will help to guide staff through 4AT assessment tools using case study examples. So back to the videos, we wanted to develop video resources, as we know that they're an effective way of delivering education and training, and obviously we can reach a really wide audience with the videos. When we looked, there were generic video resources about delirium, but there was very limited resources about delirium experienced by terminally ill people. So we saw that there was a gap there. So our aim was to produce 2 animated videos which would provide evidence-based guidance about delirium care. So our first video, which you can see at the top of the screen here, is supporting people with delirium. And this is an information resource for families, informal carers. And in it, we explain what delirium is, its causes, and very briefly how it's treated. But the focus is really on how family members can support the person experiencing delirium. So really focusing on the non-pharmacological strategies that they can get involved with so that they can support their loved one. Our second video, Caring for Someone with Delirium, is a training video for healthcare professionals. And this video focuses on delirium assessment and management. And our aim was to co-produce the videos. So we worked with a video creator who had extensive experience of creating videos on health-related topics. We also worked closely with our colleagues in Information and Support Service, who were able to give us advice on the language we were using, what level and what age we needed to pitch our videos at. We created draft scripts, and then we got extensive feedback from healthcare professional colleagues in the field and some international delirium experts, as well as PPI feedback from the Marie Curie Research Voices group, as well as our own PPI member in our immediate working team. So these videos are now embedded in the Marie Curie, on the Marie Curie website and in our YouTube channels, and they're also now available on some international sites as well. For example, the American Delirium Society, the European Delirium Association, and the All Ireland Institute for Hospice and Palliative Care. You can see the QR codes here on the screen, and hopefully the links are also now in the chat. So I'm now going to play our healthcare professional video for you, and there should be some time after that for some questions.
Caring for someone with delirium. Delirium is a serious and distressing condition which causes a sudden change in how a person thinks and behaves. It is a sign the person is physically unwell. This video explains how to recognize delirium and ways to treat it. How common is delirium? Delirium is common in people with terminal illnesses like advanced cancer or dementia. It affects up to 20% of adults admitted to hospital and 35% of those admitted to hospices. Delirium becomes more common as people approach the end of life. What are the symptoms of delirium? Delirium usually starts suddenly over a few hours or days. Symptoms of delirium may come and go and sometimes get worse at night. Delirium may cause a person to feel confused. They may not know where they are or recognize the people around them. They may have difficulty talking. They may say or do things that are out of character. They may experience auditory or visual hallucinations or think that people are trying to harm them. This can make them fearful of the people trying to care for them. There are 3 types of delirium: hyperactive, hypoactive, and mixed delirium. Hyperactive delirium is when the person is restless and agitated. Hypoactive delirium is when the person seems withdrawn, slowed up, or drowsy. A person with mixed delirium has symptoms which fluctuate between hyperactive and hypoactive delirium. What causes delirium? Delirium may be caused by medical conditions, such as being dehydrated, having an infection, having poorly controlled pain, or being constipated. Liver or renal failure and metabolic imbalances like hypercalcemia are other causes. Delirium may develop after surgery or be related to medicines, especially sedatives or strong analgesics. Withdrawal from medicines and alcohol may also cause delirium. Unfortunately, delirium often gets missed or is recognized late. Hypoactive delirium is sometimes mistaken for the person being depressed, having dementia, or being very tired. Identifying delirium. Identifying delirium early is important as it increases the chance of the person getting better and helps us provide better care. If you are concerned about a recent change in how a person thinks and behaves, consider delirium as a cause. Delirium detection tools can be used as they help healthcare staff to identify delirium, more than using clinical judgment alone. The 4AT or 4A's test is a quick and easy test for delirium. It can be used by healthcare professionals when delirium is suspected, or routinely to screen or check for delirium when people move to a new place of care, such as a hospital, hospice, or care home. The 4A's stand for the 4 items that are tested: alertness, abbreviated mental test 4, attention, and acute change. Alertness is seeing if the person is drowsy, sleepy, or agitated. The abbreviated mental test 4 asks the person their age, date of birth, where they are now, and the current year. Attention is tested by asking the person to list the months of the year in backwards order. For acute change or fluctuating cause, consider any significant changes in their mental function that have arisen over the past 2 weeks and are still present in the last 24 hours. If the person is unable to tell you, ask those who know them best, like family, friends, or carers. The 4AT takes just a few minutes to complete and can be used to test all patients, even those too sleepy or agitated to answer questions. No special training is needed to use the 4AT, but it's helpful to have some knowledge about delirium. If you want more information, visit the 4AT website. The link is at the end of this video, or ask a senior colleague for advice. If delirium is suspected, use the term delirium or possible delirium rather than non-specific words like confusion. This helps share understanding with others and will improve the person's care. Treating delirium. Delirium usually improves if we can find and treat the underlying causes. For example, giving antibiotics for an infection, encouraging the person to drink more fluids if dehydrated, or reviewing their medication if that is considered the trigger. Ensuring a calm and supportive environment is also important in caring for the person. Here are some ways that families and healthcare staff can help. Talk in simple sentences about familiar things. Remind them where they are and what is happening around them. If they find it difficult to talk, ask simple questions where they can give yes or no answers. Consider asking, "Do you feel frightened?" or "Are you in pain?" If the person is distressed, try to find out and address what's causing this. Let them know they are okay, especially if they seem worried. If they believe things that are not true, be kind and reassuring. If they think somebody is trying to harm them, let them know they are safe. Gentle touch can be calming. Have a clock nearby so they can see the time. Use familiar photos or favourite items to help engage with the person. Listening to familiar music or sounds may also be helpful, but avoid loud noises and too many visitors. Help them to drink and eat. Make sure they are wearing their glasses and hearing aids if they need them. Ensure they have access to an interpreter if required. Support them to remain active. Help them to sit up or move around if they can safely. Offer to take them near a window to get some natural daylight if they can't go outside. A good sleep routine is also important. Avoid giving drinks with caffeine after lunchtime, as caffeine blocks the sleep-inducing chemical in the brain. Offer decaffeinated drinks instead to help the person sleep better. Ensure it is quiet and the lighting is dimmed at night. We know it can be worrying to see someone with delirium, so remember to explain what's happening to those close to the person and offer them support. Medicines such as benzodiazepines and antipsychotics can be used to treat delirium, but only if the person is distressed and other strategies have not helped. This is because these medicines can worsen delirium and cause other adverse effects. If these medicines are required, it is recommended to use the lowest dose for the shortest time. Delirium usually gets better if the underlying causes are treated. Recovery may take a few days, but can take longer. However, if the person is approaching the end of their life, they may not recover from their delirium. In this case, care should focus on the person's comfort. People with delirium in the last hours or days of life are usually sleepy and drowsy. Occasionally, the person may become agitated and distressed. They may call out in a confused way and be restless and fidgety. This is sometimes called terminal agitation. Medicines may be needed to ensure the person remains calm and comfortable as they are dying. Key messages. Delirium is a serious condition, but there are ways we can help. Key points to remember are: use the 4AT to help detect delirium. Find and treat reversible causes of the delirium. Find ways to help the person feel calm and safe. Only use benzodiazepines and antipsychotics to treat distress when other ways have not helped. Offer support to those close to the person and show how they can help. If you want to find out more about delirium, here are some useful resources. You can get more information about the 4AT at www.the4at.com. And you can also find information in the Marie Curie Palliative Care Knowledge Zone, Information for Professionals, at www.mariecurie.org.uk, or scan the QR code.
So thanks for listening. Here are our contact details, and please, if anybody wants to get in touch, please don't hesitate. Thank you. And I'll now just stop sharing. And I think we've got for questions.
Thanks very much, Hilary. Yes, we do. We have lots of time for questions. So thanks so much to Anne and to Hilary for presenting that work, and Hilary for showing the video resource. Just to mention that there are links to both the healthcare professionals video and also the patient video that's been put in the chat. So please, feel free to use these resources. They're on the information and support web pages of the Marie Curie information and support resource. And we're trying to look at other places to disseminate the videos, just with an idea that these may be helpful resources more widely than within specialist palliative care. Obviously, they're aimed at palliative care patients in any care setting, including care homes. So if anybody has any ideas about where we might be able to disseminate the resources, that would be really useful. So yeah, just looking at the questions at the chat, questions coming in. Deborah Penfold saying, is there any evidence or information on using the 4AT in the community or in virtual ward settings? So I'm not aware of anything so far in palliative care. I know there are studies looking at use of the 4AT in community settings in care of the elderly medicine, but I think not in palliative care. I'm just looking to Anne and Hilary for backup on that. And any ideas? Anne,
yeah, I agree, Juliet. I don't think there's anything on the use of the 4AT in community palliative care settings, but there is evidence on the 4AT, I think, in more generally in detecting delirium in older adults in the community. And there's a number of links on the 4AT website to all the studies that have been conducted that have used the 4AT. So that's probably a useful resource also for anyone interested in that. But yeah, that would be a really nice next step to look at the use of the 4AT in the community setting.
Yeah, I think that would be a great project if anybody's looking for something to do with delirium in community settings. A validation study would be, I think, extremely difficult in palliative care patients in community settings, but equally, if you're up for a challenge, I think that would be a great resource to have. So next question, how can delirium, so this is Akumi Okamoto, how can delirium be identified in individuals with pre-existing dementia, given the similarity in symptoms between the two conditions? Fantastic question. Thank you so much. Yeah, this is a real challenge, and it's one of the clinical dilemmas that we face a lot, and often I think we in patients who have dementia, we know that these patients are at greater risk of developing delirium. So I think that's evidence that comes through very clearly from geriatric medicine, as well as acute medicine studies to do with delirium. So these are a vulnerable group of patients, and again in terms that you're looking for the people who know that patient the best. You're looking for something different in terms of time scale. So in the last days to short weeks, there has been a change in cognitive function. So even at baseline, so the people who know the patient the best will know what their baseline function is. So you're looking for a change. And then the other aspects of the diagnostic criteria do allow you to distinguish it from dementia. Often it is a much more global cognitive impairment, but it may be that there are different symptoms coming through that were not part of the pre-existing dementia. So I think it is a diagnostic challenge, but the 4AT has rated quite highly in terms of allowing that distinction to be made. So using the 4AT in patients with dementia allows you to actually determine which of those patients have delirium. So again, I think that work hasn't happened within palliative care, but has happened in other care settings. So I think it would just reinforce the need to use a specific screening tool. And have you got any Any thoughts around that question? You're not aware of any other research?
No, I think that's well covered it well.
Good. Okay, so another question from Pretty Manimo. I come from a culture that believes delirium is a form of evil spirit's attack. If I came across such a family, how can I help them understand and manage delirium? Very good question. Again, Anne or Hilary, do you want to pick up on that one? Or?
Yeah, that's a really interesting question, and I think it would be very helpful for us to look at the acceptability and value of, for example, our resources for people from different cultural backgrounds or where people have different beliefs. So obviously we have had a lot of feedback from stakeholders and our own PPI groups, but we definitely could go wider in terms of looking at, cultural differences in terms of how people perceive the value of some of these strategies that we've shared. I mean, it would be interesting to see if some of the general strategies around offering reassurance and supporting the person in terms of, drinking and, moving around, whether they would still be helpful given a different understanding of the cause of delirium or the nature of delirium, whether some of these strategies would still be helpful. Hopefully they would, but I think that is also another really useful question for research and looking at adapting our resources for a more diverse audience. So thank you for that. And I think that's one that we should look at.
Thank you.
And I think just to add as well, I think I think I would be using our videos. I think our patient and family video is a much shorter version of the video that we've just shown. And that might be a really useful resource for a family like that to maybe better understand a little bit more about delirium, but also what they can do to help their loved one.
And I guess I'm just wondering if there might be potential within the way that the video is shown at the moment to change the there are subtitles on the video, and it may be possible to change to a different language within the subtitling option of the video as it stands. I mean, I think as Anne's mentioned, we are looking at targeting different cultural audiences, different language audiences with the videos specifically. But I think that at present there are subtitles which probably could be adapted for different languages at the moment. I think the whole idea of hallucinations, I think particularly, and delusions as being part and parcel of the dying process is a really interesting one. The existential distress around the dying process is and often people have hallucinations or vivid dreams, which can be quite helpful or sometimes worrying. So I guess I would be encouraging staff to think about the impact on the patient. If a hallucination is positive and helpful, then clearly that's not something you need to be intervening with. But you're still, with the unpredictable nature of delirium, a helpful and soothing hallucination one night might turn into something quite terrifying and fearful the next night. So I would still be emphasizing the importance of detecting delirium and intervening to try and make sure that it's a manageable thing, particularly around end-of-life care. But near-death experiences and hallucinations, and that's a whole different research area in itself. But it's quite interesting to think about the potential interface with delirium. Thank you very much. Okay, we have a question from Julie O'Keefe. If large numbers of patients are misdiagnosed as depressed rather than hypoactive delirium, what should we look for as the differentials? Okay, very good question again. Anne, do you want to take that one? Or do you want me to?
I might leave. Sorry, I think just as I might leave that one to you, Juliet.
Yeah. So no, sure. Yeah. So I think I would just bring the focus back to using a screening tool, because it's I think the classic area of the diagnostic criteria that distinguish from depression, plain simple depression, focuses around the inattention and the cognitive the cognitive problems. So that comes out very much when you start to use the formal screening tool. So months of the year backwards, that's that is quite a useful tool. It can, until you get into the habit of using it, it can feel quite clunky. But once you're using it and once you see the impact, somebody who maybe doesn't come across as muddled in the slightest, as soon as you ask them to do a cognitive task and can show and demonstrate that they do actually have cognitive impairment, I think then you start to see the usefulness. Because somebody who's just slowed down and depressed, won't have the cognitive impairment that's characteristic of delirium. So again, I would just, if you're in any doubt, I think just bringing people back to using the screening tool is very helpful. There's another question. Sorry, I'm just linking back to the question and answer, where we've got a few minutes left. We've got something from Eleanor Panzai. Our study identified that clinical teams frequently misinterpreted hyperactive delirium as terminal agitation, which had a significant impact on the management strategies and interventions chosen for patient care. Given the similarities in clinical presentation between delirium and terminal agitation, distinguishing between the two remains a challenge. To evidence accuracy in diagnosis and intervention, how can healthcare professionals be better supported in adopting a more structured approach, one that prioritizes the identification and management of potentially reversible causes in delirium? Additionally, when is the appropriate time to transition from delirium-specific management strategies to those focused on terminal agitation? And that's so very interesting point, Eleanor. And I guess I would encourage people to focus less on distinguishing between delirium and terminal agitation. I think it's all the same spectrum. So delirium at the end of life often is terminal agitation. That's where I think that those two things are the same. The difference is how much you're looking for a reversible cause, or how much you're focusing in on keeping somebody settled and comfortable and just on symptom management rather than reversing. And that's all about, that's clinical diagnosis. And I agree, it's a really, really important point, because often people who have terminal agitation do present as if they're acutely dying. And that, I think anybody working in acute palliative care inpatient settings will have seen patients coming in diagnosed as dying, agitated, and then it's simply that they had hyperactive delirium or hypoactive delirium, and reversing the underlying cause, actually they recover and have more good quality time left. So it's a really important clinical education area to highlight for anyone working in palliative care settings, or any clinical teams working in acute hospital settings, I think, to distinguish between the two. But the non-medicine management strategies for delirium work even in the terminal stages. So I would still be focusing on environmental strategies, multidisciplinary team approach at end of life, family education. All of the same strategies work. So I think it's important to look at the holistic aspect of that, rather than just looking at delirium management as focusing on the reversible causes entirely. I think the multidisciplinary approach is helpful. And then it's just one final, before we finish, it's just an opportunity, I think, to talk about what we've got planned. And Ellen has also asked, what are the most effective non-pharmacological interventions for managing delirium in palliative care settings? So, Anne, I don't know if you want to mention the review that we're just about to do.
Oh, yeah. So that's a really good question, and it is quite difficult to tease apart the effectiveness of one strategy over the other. But we've just embarked on and we're conducting an integrative review of all the evidence on approaches to delirium management in palliative care settings that has been conducted since 1980. So we will be bringing that together, and hopefully we will be able to share that and share the findings from that later on this year. So Hopefully that will be useful to just guide practice and further guide guidelines in this area.
Yeah. Thank you so much. Yeah, so I think, yeah, watch this space. I think that's an emerging area, and you know, welcome anyone who's looking at doing research in that area. That would be very useful. Thank you. Well, that brings our session to a close, and thank you so much to Anne and to Hilary for their input to this part of the session, and thanks in absentia to Dr. Liz Arnold, as I say, who's unfortunately not able to be with us today, but she's led on a lot of work that we've presented here, so that it's important to acknowledge her part in today's presentation as well. And she was the voiceover for the video that you heard as well. So thank you so much, and I hope you've enjoyed both of the sessions today in this morning's conference, and please do check out the rest of the programme. And also just remember that all of the links to the resources that you've seen today are in the conference platform. You can get any of the links that have been talked about today, so that you can go back and look at it in your own time. Also, just to highlight, we've got the conference posters and the presentations, and they're all available on the conference platform. So please do take some time to go and have a look at the posters. So just last thanks to everybody, and thank you to you who've been watching for your input and your attention. And I hope you have a good break for lunch, and enjoy the rest of the conference. Thank you very much.
Thanks, Juliet.
Thank you. Bye for now.